Hi, this is Brian Kim. I'm going to share with you this case of an IOL exchange I did on a Tecnis multifocal for a Symfony extended depth of focus lens. This is a patient who had a Tecnis multifocal lens implant, wanted to see well with the lens. I worked with him for almost a year, and he just couldn't see out of this lens. We optimized his ocular surface. We did macular OCTs. We did all sorts of analysis to really figure out why he wasn't seeing well out of this lens. And essentially, what we discovered was he just really couldn't see with the optics of a Tecnis multifocal. So we opted to do a lens exchange. Since it was nearly a year since his original surgery, I decided to make new incisions. I made paracenteses superiorly and inferiorly. I injected intracameral lidocaine and then dispersive viscoelastic. I didn't do an aggressive fill because we're not really doing cataract surgery. I make my triplanar corneal incision, I make a vertical groove and then tunnel and then enter the anterior chamber. And then I use either a 25 gauge or a 27 gauge needle mounted with the dispersive viscoelastic. And I go bevel down, I get underneath the anterior capsular rhexis edge, and I push the dispersive viscoelastic. I try to approach it from different angles, first from the main incision and then the paracentesis incision. Some people are scared about puncturing the anterior capsule using the needle. I've been using this technique for many cases, and I really haven't had any issues with puncturing the anterior capsule, especially months or years after surgery. The anterior capsule is really fibrosed. And if it's a new case, the capsule is not really very adherent. And so it's easy to lift up on the anterior capsule, do kind of a side-to-side wiggle movement, and then push that dispersive viscoelastic in. Once you're able to get a little bit of space between the capsule and the lens, you can switch to your dispersive viscoelastic cannula and just gently push the dispersive viscoelastic into the capsular fornix. You're trying to sweep side to side, again, creating that space between the anterior capsule and the lens. And by creating that space, you're also able to push more dispersive viscoelastic into the capsular fornix. You can see I'm doing a side-to-side movement doing that. It's amazing, despite doing a very thorough cleanup at the end of the cataract surgery, you can see months later, you can see this lens material still within the bag. So I'm able to go around circumferentially through all of my incisions. Again, I'm getting underneath the anterior capsule edge, and I'm sweeping with the cannula, and I'm pushing viscoelastic as I go. I'm making sure that that viscoelastic is pushing and visco dissecting and separating the anterior capsule from the lens, as well as pushing the anterior capsule away from the posterior capsule on the edges peripheral to the optic. I then go underneath through my main incision and push more dispersive viscoelastic underneath the lens to make sure the lens is completely freed and dissected off the posterior capsule. Once I'm very confident that the entire lens is free from the capsular bag, I'm using a Sinskey hook to pull on the optic haptic junction. And as I do this, the haptic is able to come out of the capsular bag very easily. I do the same maneuver on the other side, pulling on the optic haptic junction. And as you can see, thankfully, this haptic was able to be released very easily, and it comes out of the capsular fornix, and I'm able to dial the lens out very nicely out of the bag. I'm placing some micro scissors and forceps in the eye now. I use my scissors to kind of push down on the optic. I'm maneuvering the optic with my scissors so that I can get a good grasp of the lens with my micro forceps. I get a good grab, and I'm able to cut the lens completely without re-grabbing with my forceps. When pulling out the lens pieces for better control, I like to use a two-handed technique. I'm still grasping the lens in my left hand after I've cut the lens. And with another forceps, I'm grasping the haptic and pulling it through the main incision. Once I pull the haptic through the main incision, I'm making sure that the lens is well controlled, and then I'm using a two-handed technique. Again, I'm grasping the haptic with one hand, and then I'm grasping the optic, because you can see the optic kind of has a point to it. And if you don't pull it out correctly, you can get it snagged in the wound. And so by grasping the haptic with one hand with the forceps and grasping the optic with the other hand with the forceps and then pulling them out together, you have a much more controlled way of pulling the lens out. And then going after the second lens, you can see that optic that's pointed towards you has a triangular configuration. You grasp the optic at the tip of that triangular tip of the lens, and you're able to pull it out very easily. I'm injecting cohesive viscoelastic in the bag, and you can see the bag is intact and it looks good. I'm delivering the Symfony lens with the injector, and then I'm going to make sure that I reposition the haptics 90 degrees. I want to make sure that both haptics are definitely in the bag. And again, doing an IOL exchange, even though this step is basically the same as doing cataract surgery, doing an IOL exchange is very different. You don't know if the bag is going to be stable. You don't know if there's going to be zonular problems when you're taking the lens out, and you can have a posterior capsule rupture in these cases. You want to be very careful when you're doing these maneuvers. Once the lens is completely in the bag, I go under the lens and remove any of the cohesive viscoelastic between the lens and the posterior capsule. And then very carefully, I'm removing the viscoelastic in the anterior chamber. The entire time, I'm going to remove any remaining lens material that might be in there from all of our maneuvers. It kind of helps liberates these little pieces of lens material. So I go after the pieces of lens material, and I'm removing any of the viscoelastic. I'm making sure there's good anterior capsule overlap over the optic, which I have. I'm removing all the viscoelastic material from the anterior chamber, and then I hydrate my incisions. And I center the central optic over the macula. So this patient, again, with the multifocal lens, he was seeing around 20/30 vision, not really very happy. We went ahead and did this exchange, and the patient was really delighted. Actually, this was his first eye. He never elected to have his second eye done until he really was frustrated with his second eye that had the cataract. During this time interval, the Symfony lens became available in the United States, and I put a Symfony in that second eye, and he was delighted with that. And that's why I was very confident he would do well with the Symfony in this Tecnis multifocal eye. So this patient was able to see 20/20 uncorrected distance and 20/25 at near with this Symfony lens. As you can see, because I put so much viscoelastic in for this entire IOL exchange, even though I did good and viscoelastic removal, when I'm doing my hydration of my incisions, you could see there's still viscoelastic in the eye. And so that's the thing. You're going to have to use a lot of viscoelastic during an IOL exchange, and you need that viscoelastic to help you visco dissect the bag open and visco dissect the lens from the bag completely. And so you're going to have a little bit more careful, diligent removal of that viscoelastic. And you can see here at the end of this case, the cornea is clear, the chamber is free of all the viscoelastic. You have a beautiful Symfony lens within the capsular bag, and it's centered over the macula. So I hope this case was helpful to you, and I thank you for your attention.